Well, the answer is we don't know. What we can, there are some considerations that can be made. If we have decided that our patient is transplant eligible and we want to transplant them and the patient is okay with the transplant, that as a prerequisite, what we know in amyloidosis is that we need a deep remission. If there is no deep remission, I would rather do it quickly, because we need that remission to be as early as possible, and then on the second run to be as long as possible, right? Now, there's also some data from myeloma. Obviously, they're not entirely comparable, but for example, one could say that we have the determination trial, which proved that late transplant is not necessarily worse, which may not apply to amyloidosis patients due to the reasons that I just discussed, but it's often something that gets into the conversation, and which also gives transplant a role in relapse of AL amyloidosis. But it's something we will have to find out in the future. Now, as a personal approach, what I usually do is I discuss high-dose chemotherapy after 3 or 6 cycles of induction therapy, and just see how response serologically is, how good response of the organs is, and if patients are still fit for it, and what the patient's plans and preferences are, because they grow as a patient, they know stuff, they inform themselves, they know how the clinic works, and so that's always also very important.